Leukemias are malignant disorders of hematopoietic stem cell compartment. Malignant disorder of hematopoietic stem cell compartment, characteristically associated with increased number of white cells in the bone marrow and or peripheral blood. Classification of leukemia according to clinical course: acute leukemia and chronic leukemia. Acute leukemia, chronic leukemia. According to the cell line predominantly involved: myeloid leukemia, lymphoid leukemia. So myeloid leukemia and lymphoid leukemia. ALL, CML. So we get 4 types of leukemia: acute myeloid leukemia, acute lymphoblastic leukemia, lymphoid leukemia, chronic lymphoid leukemia, chronic myeloid leukemia. Now a case: how we do investigation. A 25-year-old male presenting with fever, gum bleeding and purpuric spots for 1 month. Possibilities are acute leukemia and aplastic anemia. Investigations include CBC with ESR, peripheral blood film, PBF, and bone marrow examination. Acute leukemia. Acute leukemia. Symptoms. The majority of patients with acute leukemia, regardless of subtype, presents with symptoms reflecting inadequate hematopoiesis secondary to leukemic cell infiltration of the bone marrow. Symptoms and signs. Symptoms include anemia, number 1. Anemia, pallor, exertional dyspnea, weakness, tiredness, and claudication. Number 2, leukopenia. Leukopenia indicates recurrent infection. Thrombocytopenia, bleeding and bruising. Number 4, bone marrow infiltration, which expressed as bone pain. And signs include number 1, pallor due to anemia. Number 2, fever due to infection, not the disease process. Then petechia purpura, bruise. Bony tenderness. Number 5, lymphadenopathy. Number 6, hepato and splenomegaly. Important investigations of acute leukemia. Includes CBC. Number 1, complete blood count or CBC. Hemoglobin percent reduced. Then WBC. In CBC we get hemoglobin percent reduced. WBC usually raised, sometimes low. Then platelet counts usually low. Number 2, peripheral blood film. Peripheral blood film study. Blast cells only test for diagnosis of leukemia. Blast cell, the only test for diagnosis of leukemia, very very important. Then bone marrow examination. Bone marrow examination done for typing of leukemia. Done for typing of leukemia. Typing acute myeloid, myeloid or lymphoid. Now we will study about differentiation of acute leukemia and aplastic anemia. How we will differentiate between acute leukemia and aplastic anemia. Acute leukemia clinical features. The clinical features of acute leukemia includes fever, bleeding, spots, and patient is toxic. And aplastic anemia, fever, bleeding, spot, but patient is non-toxic. Here patient is toxic and here patient is non-toxic. The number 2, anemia, mild to, in case of acute leukemia, anemia is mild to moderate, and in case of aplastic anemia it is severe. It is a main manifestation of aplastic anemia. Then bony tenderness. Bony tenderness is present in case of leukemia but absent in aplastic anemia. Then hepatosplenomegaly and lymphadenopathy is present in but absent in aplastic anemia. Peripheral blood film shows leukocytosis with blast cell. Here we get blast cell, and in case of aplastic anemia we get pancytopenia. And bone marrow, again blast cells, and we get hypoplasia or dry tap. Hypoplasia or dry tap in case of aplastic. A patient presented with gum bleeding and purpuric spot. Now, what are the differential diagnoses you will consider? Again, acute leukemia, gum bleeding, we get it from acute leukemia, aplastic anemia, and idiopathic, and here you get purpuric spot, idiopathic thrombocytopenic purpura. Investigations with expected findings. Hemoglobin percent mild to moderate, severe, and in case of idiopathic thrombocytopenic purpura it is normal. PBF, we get leukocytosis with blast cell. Here we get pancytopenia. Here we get thrombocytopenia, idiopathic thrombocytopenic purpura. So we get thrombocytopenia. Bone marrow examination. Here we get blast cell. Here we get hypoplasia or dry tap, and we get megakaryocytosis. Acute myeloid leukemia, AML, acute myeloid leukemia, acute lymphoblastic leukemia. Now we will study about acute myeloid leukemia and acute lymphoblastic leukemia. It is very important, and we will study about this. acute lymphoblastic leukemia. Acute lymphoblastic leukemia. Clinical features includes symptoms and signs. The signs and symptoms of acute lymphoid leukemia and acute myeloid leukemia are same. Acute myeloid leukemia are same. So acute lymphoid leukemia symptoms and signs. Symptoms include fever with or without identifiable infection. Fever with or without identifiable infection, bleeding manifestation are easy, bruising, fatigue, breathlessness, angina, and claudication. Then bone pain. Signs include pallor, raised temperature, sternal tenderness, lymphadenopathy, hepatosplenomegaly, then evidence of infection, evidence of hemorrhage, and retinal hemorrhage, and detected in 15% of patients. These are clinical features. Now, laboratory diagnosis of acute lymphoblastic leukemia. Now, laboratory diagnosis acute lymphoblastic leukemia: blood count, peripheral blood film, and bone marrow blood. Number 1, CBC include hemoglobin percent is reduced, WBC usually raised, sometimes low, platelets low, peripheral blood film. Number 2, peripheral blood film, blast cells almost invariably seen, lineage identified, morphologically smear cells are present in acute lymphoblastic leukemia. So blast cell plus smear cells. Now number 3, bone marrow examination. Hypercellular bone marrow with blast cells and reduced megakaryopoiesis. Hypercellular bone marrow with blast cells. Hypercellular bone marrow with blast cell and reduced megakaryocytosis. Treatment of acute lymphoblastic leukemia. Supportive therapy and chemotherapy. Supportive therapy includes blood transfusion, platelet transfusion, and control of infection. Then chemotherapy it includes remission induction, remission consolidation, remission maintenance, and relapse. Remission induction, remission consolidation, and remission maintenance. Finally, relapse. Remission induction drugs are vincristine, prednisolone oral, L-asparginase intramuscular, then daunorubicin IV, methotrexate intrathecal, and imatinib oral. Remission consolidation includes daunorubicin, intravenous IV, cytarabine IV, etoposide IV, methotrexate IV, and imatinib oral. Remission maintenance, prednisolone oral, vincristine IV, then marcaptopurine oral, methotrexate oral, imatinib oral. Relapse. Then relapse includes fludarabine, cytarabine, and idarubicin. Allogenic number treatment supportive therapy, chemotherapy, and finally allogenic hematopoietic stem cell transplantation. Number C, allogenic hematopoietic stem cell transplantation. Chronic leukemia, chronic myeloid leukemia, and chronic lymphocytic leukemia. We need only chronic leukemia. Chronic leukemia includes chronic myeloid leukemia, chronic lymphoblastic leukemia. We need only treatment of chronic myeloid leukemia. At control phase and at accelerated phase and blast crisis. Control phase, first line therapy, second line therapy, then allogenic hematopoietic stem cell transplantation and classical cytotoxic drugs. First line therapy, we get tyrosine kinase inhibitors. Example, imatinib, nilotinib, or dasatinib. Imatinib. Second line therapy, above mentioned tyrosine kinase inhibitor, which is not used as first line therapy. Then allogenic hematopoietic stem cell transplantation for people who fail tyrosine kinase inhibitor therapy. Then classical cytotoxic drugs. Such as hydroxycarbamide or hydroxyurea or interferon. Hydroxycarbamide or interferon. Accelerated phase. In accelerated phase, we use tyrosine kinase inhibitors. Example, nilotinib and dasatinib. Then treatment of acute leukemia, allogenic hematopoietic stem cell transplantation in younger and fetal patients, and hydroxycarbamide can be effective single agent, and low dose cytarabine can also be used palliatively in older patients.